primary veterinarians are sort of like apologetic about a referral for a mast cell tumor sitting on a dog, and I think as an oncologist, like these are great cases to send to me before anything's really been done because I like to be able to sort of outline all the options to the owner, what works for you, and we start with one and see what happens. Or if at any point it's getting worse, we flip to another one.
Hey everyone, welcome back to VetFolio Voice. In this episode, I was joined by veterinary oncologist Dr. Joanne Intile, who provided so much clarity about all those times I've encountered such frustration around treating mast cell tumors. I mean, these little masses, they can be infuriating at times, am I right? But Dr. Intile said something that really resonated with me. She said when she talks to clients about mast cell tumors, she tells them that she'll explain everything she can about the expected course, the staging, the treatment. But if ever there was a tumor that was going to break every rule and do the opposite of what she expected, it was a mast cell tumor. Guys, I felt so seen, so reassured that some of the frustrations that I've encountered with mast cell tumors in the past were just due to the fact that these tumors are by nature complicated and unpredictable. That said, Dr. Intile did leave me with hope. She shared her approach to staging, treatment strategies, and the nuances around interpreting pathology reports in order to do the best we can to make good recommendations for our patients in the midst of what can be very unpredictable. So, if you've ever been humbled by a mast cell tumor, or if you'd just like to learn more about these sneaky little masses, this is a great episode. Dr. Joanne Intile earned her DVM from Cornell University and completed a rotating internship in small animal medicine and surgery at Long Island Veterinary Specialist before returning to Cornell for a residency in medical oncology. She went on to practice in private specialty hospitals in New York and Maryland, but her passion for teaching ultimately led her back to academia. After serving as an adjunct instructor at Suffolk County Community College, she joined the faculty at NC State's College of Veterinary Medicine in 2017, where she continues to combine clinical expertise with a commitment to educating the next generation of veterinary professionals.
Looking to protect your canine patients against parasites? Look no further than Simparica Trio, Serolaner Moxidectin and Pyrantel chewable tablets. The first chewable to offer triple protection from heartworm disease, ticks and fleas, and roundworms and hookworms. It's also FDA approved to block infections that may cause Lyme disease by killing deer ticks.
Use with caution in dogs with a history of seizures. Serolaner belongs to the isoxazoline class, which has been associated with neurologic adverse reactions. The most common side effects were vomiting and diarrhea.
Visit SimparicatRioDVM.com for full prescribing information.
Well, I'm excited. Dr. Intile, thank you so much for joining me. We're talking about a topic that I think many of us struggle with, definitely in private practice. And I'm starting to get the sense that perhaps in specialty practice as well, and that's mast cell tumors.
Yeah, definitely a very frustrating tumor type that we deal with and a very common tumor type. So, yeah, for sure.
Thinking about those, yes, they are frustrating. Is there anything we can do to like keep them from coming up? Because it used to be, oh, I see this mass and I can kind of get an idea with my eyeballs and it's a definitive diagnosis under the microscope. So yes, I have my diagnosis and all right, but now I see them and I get that definitive diagnosis and I'm like, oh no, now we have to have a serious talk with the owner about what this is going to continue to look like. Is there anything we can do like preventatively to reduce the incidence of mast cell tumors?
That's a great question, and I sure wish there were something that we could do to prevent them. They unfortunately are very common, and there's likely some genetic component to the development of these tumors because we definitely see them in certain breeds more frequently than others. Your boxers, your B breeds, your Bostons, etc. But plenty of mixed breed dogs get these tumors and we don't know why they happen. And once a dog gets one mast cell tumor, I'll usually warn an owner, you've probably got, close to a 20% chance you'll get another one at some point. And then once you get two, it's probably like 50-50. So yeah, I wish we could prevent them, but the good news is overall, many of them are, I call them nice players, but there's a subset that are not the nice ones. And that's obviously a shared frustration. I think you're expressing and I'm expressing as well.
Sure, sure. And I love the way you put that they're nice players because it's like how do we actually interpret these? How do we actually grade them and what are they going to do? And that's one of the other pieces that can be really frustrating around mast cell tumors is how do we interpret what we're seeing? Because at least, to my limited understanding, we can't tell which ones are the nice ones and the not so nice ones just from doing an aspirate. We are talking surgery to remove the tumor in histopath and potentially having to repeat that if we're getting recurrence. So, poor Franken puppy sometimes.
Yeah, so grade is histologic grade is our biggest predictor of sort of biologic behavior in dogs. But even at that, it's not a perfect system. I feel pretty confident. We have the Patnick scale, the 1, 2, and 3, and the Cupel scale, the low and the high grade. And if anywhere on there I read grade 1, I'm fairly confident that that tumor is going to be one of those nice players. If I see grade 3 anywhere on there, I'm pretty certain that's going to be a more aggressive one. But it's when you get the grade 2 right in the middle, or sometimes the subsets of grade 2s that can either be a grade 2 low grade or a grade 2 high grade. Those are the most unpredictable of the groups, and you really can only determine that with histopath. There is becoming more popular this idea of cytological grading of mast cell tumors, but it's not catching on. I wouldn't say it's sort of widely accepted. My general rule of thumb is if you aspirate a mass and you can identify that there are mast cells on your aspirate, it's hopefully not going to be a grade 3, but it still could be a grade 2 high grade or a grade 2 low grade. If you aspirate a growth on a dog and you just see a bunch of round cells and you're like, I don't really know what these are, that is more concerning. And that probably will be more consistent if it is a mast cell tumor with a grade 3 or a high grade tumor. But yeah, you need that histopath. And for owners of dogs that get multiple tumors, that is definitely a shared frustration. It's multiple anesthetic episodes, multiple costs with these biopsies, and it is a teaching point, and I think important to drive home for them.
Right. Yeah. Communicating that early. And I think that's always where, like, I get the shoulder slump and I'm like, oh gosh. And especially if it's the second one,
Hmm.
like that first one, I still hold out hope. Maybe we got the one and we can get rid of it and be done. But if it's the second one, yeah, that communication can be really challenging with owners and preparing them for that potential road. But I will say, listening to you, I did feel very validated and empowered there in GP because yeah, sometimes when I'm recommending these multiple surgeries to remove mast cell tumors and knowing that like we might just have to go back and do this again if this dog pops up with more and we're submitting for histo every time ideally, sometimes we don't get the chance to. I do appreciate what you said there and that really is the right thing to do. It feels like so much,
Hmm.
but we have to get them off of there in order to really figure out what we're dealing with. And in true mast cell form, it sounds like even when we do, there are times where we still don't know what they're going to do.
Yeah, and as an oncologist who sees a lot of these patients, I can recount many patients who have had multiple low-grade tumors taken off, and then their fifth and sixth or whatever might be beyond that is the high-grade one. So you're never quite off the hook is the other thing, and I think that is a common theme questions I get from primary vets. I've taken 4 low-grade tumors off of this dog. We have a new mast cell tumor. Do I really need to submit this for histopath? And I'm like, yes, because that may not be related. It's probably not related at all to any of the other tumors, and it could be a whole different ballgame that you're dealing with.
Ah, the worst.
Yeah.
Gosh. So you talked about cytologic grading and, seeing definitive mast cell tumors versus kind of these vague round cells. I'll be honest, I don't think I trust myself to make that distinction and make that identification. But if we get information back, say we submit a slide and we get a report back on our cytology, and it has some information in terms of grading and, either maybe suspect high or low grade or something like that, how much stock should we be putting in that?
I think if your cytology were to return from a clinical pathologist and say there is concern that this is a high grade tumor based on cytology, I would put a lot of weight into that,
Okay.
namely because the features that they're going to be identifying are probably, the lack of those really nice purple granules that we typically see, a lot of variation in the cell size or nuclear size. And then we'll also see on cytology frequently of those high grade tumors like multinucleated cells and all of those features, which in your nice playing mast cell tumor on cytology, you usually don't observe those things. So I would be very worried about that on cytology personally. And that might be a tumor where either from the sort of jump you have an owner in a situation where you're like, I'm going to refer you to an oncologist right now to talk about this and talk about your options. I'm worried about this, or, I'm going to maybe, if you're going to take it in your clinic and take that off, try to go with margins that I always say my general scheme is, take as much as you're comfortable with and just a little bit more if you can. So that might be one where you take a little bit more on it because of the concern of the high grade.
So if we get a report back, a cytology report back, and it suggests that we're looking at a high grade mast cell tumor, those we should put a lot of stock into and say, we need to get aggressive with this one off the bat and potentially talk about referral staging, all these things. But maybe if we get it back and it says a low grade or, we're not concerned for a high grade, those we should still take that with a grain of salt and be cautious with those.
Yeah, because those are, you're getting a small little sample with your needle that you're sticking into that mass, and maybe you're not getting all the representative areas. So I think you still have to be cautious. They're tricky for
Sure.
sure.
They are tricky.
Yeah. And I think this is a really good tumor type to me where I think primary veterinarians are sort of like, oh, apologetic about a referral for a mast cell tumor sitting on a dog, and I think as an oncologist, like these are great cases to send to me before anything's really been done because I like to be able to sort of outline all the options to the owner. First, do we stage this patient first? Do you want to do that? Do you want to go ahead and just take this off and figure out the grade and then decide if you want to do the staging? And then kind of here's all the different avenues, what this might look like. We lay it out sort of in this algorithm for them, and it may confuse some owners, but I also think it sort of sets the stage of like, hopefully this is one we can just take off and not worry about, but also I think you should be prepared to know what the staging might look like and what other options might look like after removal, if that's the way that you want to go for it.
I'm so glad that you said that because yes, that is my feeling with referral is like, I'm sorry, it's a mast cell tumor. I probably could have handled this and taken this off, but for one reason or another, referral was the appropriate option for that patient. So that's good to know that no, it is appropriate to refer these cases and don't assume just because it's easy to identify under the microscope in so many cases that it's going to do anything else to make life easier.
Really, it depends on obviously your local oncologist and sort of what their philosophies are, but I don't think there are very many that would find that type of referral inappropriate at all. And even if the bottom line is we send them right back to you to do that surgery, I feel like those pet owners are more empowered to kind of have at least heard this may not be even if that's all they ever want to do with it is just surgery, that there may be other things that we would want to do after that or recommend doing or that give us a little bit of a pause. So yeah, absolutely.
Oh, that's really good to know. And along the lines, talking about staging, can you talk a little bit about the utility of staging? I know with these, oftentimes we're not looking at chest rads, it's more abdominal. And from what I understand, these are infiltrative. So we may be having to do aspirates and of maybe spleen and liver, things like that to really get an answer. Are they usually, if we do have one that has metastasized or is disseminated, is it disseminated enough that we can get good answers on that staging?
Yeah, for sort of these unpredictable little tumors, the one thing they sort of like to do predictably is their pattern of spread. So if they're growing in the skin, especially cutaneous, subcutaneous is sort of like its own little bubble as well. But if you're talking about one of those skin mast cell tumors, they like to go to the local lymph node first, then go to liver and spleen. Again, sometimes they skip it, or sometimes we're just bad about picking what that local lymph node might be because the tumor's just growing in an area that maybe it's just harder to tell, like it's on the side of the dog or the flank. Or again, they're tricky and they I've seen so many mast cell tumors that are kind of like just above the knee that are like, I'm actually going to spread to the popliteal. I'm going to go low. I'm not going to go high.
Ah,
But they like to do that lymph node pattern and then internal spread. So at minimum, I think if you can talk to an owner about like, hey, I think we have this mast cell tumor, and I would recommend checking that lymph node in-house that's closest to it, because if that looks good, you know, maybe then our chance of it spreading internally would be less. If it's hit that lymph node already, when they come here, definitely for a referral, we will talk about ultrasound with automatic liver and spleen aspirates because they can look completely normal on the ultrasound. They can have completely normal blood work, nothing, not even seemingly be ill, and then you aspirate and there are mast cells seen in those tissues. So
oh, and those are the saddest cases when you get the disseminated mast cells and they become symptomatic. Those poor pups. It's not a nice disease.
yeah, they can be quite sick and very challenging to manage for sure.
Absolutely. You mentioned before that there might be other things that we can do in the cases of these tumors. What about injectables like Stelfonta for managing mast cell tumors?
Yeah, so Stelfonta is a newer option for treating mast cell tumors. Obviously, it's a non-surgical option. It's a drug that's injected right into those tumors, and it's designed to essentially destroy them locally, cut off their blood supply. The tumors basically die. They fall off. A little wound, well, maybe not little, depending on where it is. A wound is created that will heal over time, and it is a great option, I think, for owners that are not going to pursue surgery for their dog. They know they're definitely not going to pursue it. It's not something that they wish to do. It shouldn't require anesthesia, so maybe a little sedation to administer, but it's not something that, if a patient is a high anesthetic risk, you should have worry about. And I think it's a really good option for treatment. There are some downsides, like everything that we deal with. And the main one is that because the tumor basically falls off and dies, is that you don't ultimately get that biopsy grade on the tumor. So you ultimately don't know if this was a high grade or a low grade tumor. So that's a risk an owner has to be willing to take, and you have to be willing to take as their provider, and a discussion. I think it's just worth a discussion with them. And the other caveat with Stelfonta is it's labeled for use in dogs with non-metastatic mast cell tumors. So ideally, those patients are staged, at least that lymph node is checked first before administration. Are there dogs out there getting Stelfonta that are not being staged? Probably. But again, going by the labeled usage, and the concern for that is that the Stelfonta might not, this is theoretical, but that the Stelfonta might not just stay where it's supposed to stay within that tumor when you inject it, and then it may somehow figure out how to traffic its way up to that lymph node and then cause tissue damage and wounds and things along the path. So that would be very undesirable for a dog. But I think it's a really good option.
Sure, sure. It sounds like case selection of, maybe we have an inoperable mass on a distal limb or something like that, where we just can't get it off with good margins, and an owner who, doesn't want to go forward with staging and things like that. They say, just get it off of there and reach for something like this. I'm glad that you bring up the non-metastatic tumor and the fact that that's theoretical, because that is my biggest fear I have when I think about using self on time. Like, what if it travels and all of a sudden, we have these wounds and make things worse? But it sounds like from what you're saying, there's not a lot, we're not seeing a lot of like documentation of that happening.
Not to my knowledge, and I believe the safety of this drug is very widely and well respected. But again, it's not actually something we do that often here at a referral hospital. I think it's probably out there in the hands of primary veterinarians who, if this were happening, I believe they would be voicing it. So
Yes.
yeah, I think it's a concern. And as we use the drug more frequently and more cases are treated, we'll learn more about it. And again, there are some restrictions in terms of the size of the tumor that can be treated with Stelfonta, location wise. Cutaneous tumors, basically anywhere on the dog. Subcutaneous need to be distal to their sort of elbow and stifle ankle region, because of the concern of, again, a subcutaneous tumor is just, you can't exactly tell where it starts and begins many times. And so when you're injecting it, the concern is that that wound that will be created under the skin, you have less control sort of keeping the drug right where the tumor is, and again creating a much bigger wound. Is it being
Sure.
used for tumors, subcutaneous tumors elsewhere? Probably. So again, careful case selection, discussion with the owners, education is really important.
Absolutely. Because I can imagine if we were seeing like, disseminated wounds and things like that, that yeah, it would just be like pure pure panic referral, like, oh my gosh, what happened? So yeah, it is good to hear that there's a good safety profile and really a good utility for this drug in certain cases. I know when we're administering Stelfonta, steroids are recommended prior to administration. Steroids are another one of those kind of head scratchers that I feel like I experience when it comes to mast cell tumors, because taking Stelfonta, for example, theoretically, this would be like a smaller tumor. And then we put them on steroids and it shrinks down, sometimes to the point where it goes away, but like, does it go away? Did we fix it? Is it going to come back? What's happening there?
Yeah, so pre-treatment with steroids is required before using Stelfonta. And it's also a strategy that we use quite frequently for sort of these larger tumors that are in bad spots. I have worked with many surgeons who have said, hey, I can get this thing off, but it'd be really better if you just kind of like shrunk it up a little bit. Can you try some steroids first? And the age-old question with that is, with Stelfonta, does it shrink and go away completely? I've seen that happen twice in two dogs with very small tumors. So we've said, okay, great, stop your steroids. Let's have the tumor come back. We visited at that point. The other concern when you're trying to take a larger tumor and shrink it with steroids is, does that allow you to then do a smaller surgery to remove
Right.
that tumor? You could go back in the literature probably 20 years and people are still asking that same question. And the general consensus from us is it doesn't usually afford you the opportunity to get less margins, because when you shrink a tumor with steroids, it probably doesn't shrink perfectly identically in all directions. So maybe it shrinks, there's some tumor cells that are left out at the edge where it was initially located. And so you need to kind of cut still that big area out of the dog. But the tumor itself will be smaller. So hopefully the concerns about things like wound healing afterwards, that type of thing would be less. But we're still gonna want you to go big on the margins for that. And I think the biggest thing with that is just again owner education of, okay, I probably can get this thing off your dog, but I'm not going to get complete margins if I do this with steroids. So just letting them know, again, we're rolling the dice and hoping that this tumor will be something like a low-grade tumor where recurrence rates are generally not that high overall.
So, if I'm understanding correctly, we're shrinking the tumor with the steroids and still going back and trying to aim for the original margins just to be on the safe side, but hopefully we've shrunk it in some directions, even if not perfectly symmetrically, so reduce the chances that we've left stray mast cells at our far margins of our incision. Like you said, reduced complications with wound healing, hopefully, and maybe reduce the complications or the risk of it coming back.
Right, because the hope is if you were to cut a mast cell tumor off and cut where your gross, your measurable diseases, and you're trying to like put tumor back to tumor, that's really hard, right? The breakdown of that is more likely. Whereas if you kind of have shrunk it and there's just kind of cells peppered along that edge, hopefully you'll have healing that will be okay. And then there's also this thought that somehow the body's immune system kind of can deal with less cells better than when it's a big mass. So maybe the immune system will be sort of, as the wound is healing or the incision is healing, and you're driving immune cells into that area, they'll also kind of be like, oh, wait a minute, there's two mast cells over here. Let me try to get rid of those versus the bigger growth itself is more likely to be resistant. So yes, I think it's a good question. I think when it comes to a tumor that's in a really tricky spot, we see these interdigital tumors that the margins are just going to be what they're going to be. If the owners don't want to amputate toes to get the tumor off, then you kind of are shrinking it up and just kind of taking what you can take out of there. And again, those are situations where probably the best thing to let them know is this is not going to be a complete excision, and we may talk to you about, post-operative radiation or just real close monitoring. And then if this were to grow back, that's the time where we're going to be stuck doing a bigger surgery at that point, and hopefully that will be years down the line.
I like the way you phrase that conversation with the pet owner to say, it's not unreasonable, even knowing that we might not get clean margins, but we may need to revisit this, but maybe we can buy some time and, keep this pet more comfortable and reduce the risk of having this big discrete tumor on the dog for any longer than necessary.
Right. And then, obviously, the longer that tumor cells are present, regardless of sort of what's been going on in that patient, they could figure out how to spread somewhere else. So that's always the other concern is act on something when you can act on it to try to avoid that as well. So those are the conversations that we also have with owners. And we see a lot of pretty terrible mast cell disease in dogs, but we see plenty of dogs that come in with a very, a 2 centimeter tumor on their side, and it is very resectable. But again, they want to kind of gather all that information about sort of where this might go.
Absolutely. And when you're having that conversation with owners, how do you talk to them about prognosis with mast cell tumors? We talked a little bit earlier about we could be doing multiple surgeries and all of this, but how do you approach the conversation with owners about, I guess, the overall prognosis for that pet, whether, I guess, 'cause there's so much nuance, high
Yeah.
grade, low grade, metastasis, all of this.
Yep. So if I don't know the grade of the tumor going into it, my sort of general spiel to the owners is most of the time, probably 80% of these are going to be the good players. And then there's 20% that are going to be the more aggressive tumor types. I can't tell you where your dog fits in right now, so I could do some staging today to get an idea of that. Even if that staging looks good today, it doesn't mean your dog is in that 80%, but it certainly gives me more comfort in recommending your surgical excision, and then we'll go ahead and get that grade and kind of try to suss it out a little bit more. Sometimes we'll use the prognostic panels. I don't know how familiar a lot of people are. I think they're becoming more mainstream because the bigger commercial labs are sort of putting on the biopsy reports like, hey, we can do this thing called a prognostic panel on this biopsy sample, which provides additional information about that tumor on a more, I call it a subcellular level. Like it's not just looking at the features of the cells, it's looking at some proteins and some things that help us understand how aggressive it would be. And that's a really good option for me. I like to add that test on for dogs that have grade 2 tumors that are low grade, where the owners are really leaning towards monitoring that patient, especially if the margins on that tumor might be a little bit where I would be like, maybe we could go back and take more tissue or we shouldn't. So I'll do that prognostic panel to hopefully support the idea that waiting and watching is a good idea. I don't think it's necessary if a biopsy comes back as a high grade tumor. I don't need that prognostic panel because I'm already pretty convinced it's going to be bad, regardless of what that says. And if it's a low grade tumor, I wouldn't think you would have a bad prognostic panel, if that makes sense. So I think learning points from that are sort of they're useful for those grade 2 tumors, is more useful for me for the grade 2 low grades, potentially useful for grade 2 high grades. They are not automatically done. That's another confusing point. I think owners are sort of like, well, why didn't my vet just do this? Or why didn't you just automatically do it? That's another step. It's another cost to them. So that may be something to discuss. And then when I know the grade of the tumor, if it's high grade and grade 3, I'm going to talk to that owner about a prognosis that may be more guarded and that we should do more for that tumor. If it's a low grade 1, we're pretty much done. And then those grade 2s, those pesky grade 2s are very much in between. So that prognostic panel can be helpful for me to understand. Do we need to do more to get better local control over this tumor? Like, do we need to go back and get more tissue, do radiation? And then what do I think the chance of this tumor spreading might be, even if it hasn't spread already, like microscopic cells, and try to figure out, do we want to talk about chemotherapy for this pet?
Perfect. And I'm so glad that you brought that up because that was kind of where my head was going of if we do need to do more for this tumor, you've mentioned potentially radiation, chemotherapy. What do we think about, if we have an owner who's asking us, okay, so what if we do need to do more? What sorts of things are recommended for these tumors?
Yeah, so my approach is different if the dog has what I call measurable disease or something that I can actually measure on them. So whether that's an actual mast cell tumor or that's a lymph node that has positive cells in it or that's liver and spleen that has positive cells in it versus I'm just worried, I'm suspicious they're somewhere in your body, but I can't really see it. So my approach is different based on that. If it's just I'm worried about your dog and I think you're at high risk for spread and I want to eradicate any microscopic cells that might be present in your body, the sort of optimal plan for them would be a combination protocol of chemotherapy. So we're using, these are drugs that are given in the hospital. They're coming here for those appointments. It's about a 6-month protocol and it alternates between 2 drugs and they're coming in for frequent treatments, blood work, monitoring. It's quite intensive over that time frame of the 6 months, but it has a nice beginning, middle, and end to it. So it's defined. And built into that is rechecking, looking for spread, usually at least 2 times over that 6-month period. And then they're kind of cut free from chemo and we monitor them. The other option in that situation, if owners are not really interested in sort of like coming into the hospital doing treatments here, is we can do at-home treatments with Palladia. So that's another option that owners can do at home. It's an oral drug that's given at home. The trickier part with that to me is while it's very convenient to do at home, it still requires monitoring. So they're usually coming in about once a month, at least for the first 3 to 6 months. And then that one has a lot sort of more, I call it like the loosey-goosey time frame of how long do we need to give this for. Usually a minimum of 6 months up to a year. And then I usually find if I've had a dog on Palladia for a year and they're tolerating it well and they're doing well, sometimes it's a little bit of a challenge to kind of get the owners to give it up. They're like,
Ah,
oh, you said the this was going to be something aggressive and that my dog's prognosis might only be about a year, and here we are, and they're doing great. So I want to keep going with it, which again is fine, but it can be a little bit harder in terms of just knowing how long we should keep them on it for. So really for me, it's sort of like owner preference of, do you like something that's really nice and defined, or do you want something that's more, ease of administration at home, but maybe we're going to be looking at something long term. For a dog that has something I can measure on their body, now we have sort of four weapons that we can use. Just within the past year or so, we have a new immune therapy option. But basically, we had, CCNU oral medication, vinblastine IV medication, Palladia that I just talked about, oral medication, and now we have this conditionally approved drug called Gilvetmab, which is a monoclonal antibody. And in that case, I basically talk to the owners about all those different options, what works for you, and we start with one and see what happens. Start with one, treat them for a month or two. Are we making progress? Is the tumor shrinking? Is whatever I've seen in your patient, is it going away? Are we getting a positive response? Great, we'll keep going. If not, let's try the next one. Or if at any point it's getting worse, we flip to another one. So that's the as a medical oncologist, probably the most common situation that I'm seeing cases, and probably the most frustrating, because trying to treat those measurable tumors with our weapons that we have, really at best, they have about a 40 to 50% chance of working. So most dogs are kind of cycling through all of those at some point. But their life is extended, I think, if they are positive responders, because again, they're getting some time where one drug is working for a few months and then we're switching to another. So it requires the right owner and the right scenario to be able to do that. But I do think they are living longer than if they have like a measurable tumor on their body that's making them not feel well or spread or something more impacting.
And then does radiation have a role in there as well?
Yeah, so to me, I kind of approach each case as like radiation is a local therapy, or what we call local regional. So that could be an option for, say, an inoperable tumor. It's kind of like the Stelfonta we were talking about, but basically you're just applying these, I call them big fancy X-ray machines, right? They just hit a lot of energy and radiation to the tumor, hopefully shrink it up. Really a successful treatment option. It can be so successful that the tumor cells die very quickly from it, and then they release all of their fun little chemicals that they have into the dog's body, and that can make them feel poorly because those chemicals are sometimes things that can cause stomach upset and other problems. So most radiation oncologists are last resort option to use radiation for big tumors. But again, I don't speak for everybody. There are probably plenty out there that are treating and successfully treating them. It's a great option. It's not something that's usually, sadly, not accessible to a lot of people. There's not a lot of radiation oncologists in our country currently or around the world. So
Sure. I know we were doing radiation at UF there for a while. I think they still are. I'm not positive, but certainly I remember some of those cases before and during vet school. But goodness, you can successfully treat them with radiation and then they die and they're like, "Oh, but you killed me too effectively and now I'm going to cause problems." I'm like you said that. I'm like, "Gosh, mast cells are the worst."
yeah, I mean, I had a dog who had a tumor on their body, but went through the whole appointment with the owner, just kind of slept in the room, was feeling really good, no problems, went through all the options, and they kind of were going to take him home to mull things over. The dog got up, they all walked into the hallway, and then the dog collapsed from a degranulation up. Like nobody even touched anything, probably more than me just measuring it. So I always warn owners, not to scare everybody completely, but it's sort of, yes, we can do things that can manipulate the tumor cells and make them angry with our therapies, but also they're prone to it. They're a
They're
little
just
bit, they're
angry
activated.
tumors.
So yeah.
Ah, do you normally pre-medicate with Benadryl if you're assessing these tumors?
So if you're going to do it like doing an aspirate or
Right.
something, yeah, I think it's a good idea. And we train our students here to think about it. You have to have it on your mind. You have to be thinking, oh, this might be a mast cell tumor. So yeah, let's go ahead and pre-medicate this patient just in case something terrible would happen. I think the risk is very low in my experience, even if you don't pre-medicate. What I've seen more frequently is sort of more of a local massive inflammation or local bleeding or bruising, not this whole like systemic collapse and cardiovascular decompensation from just poking it
Sure.
with a needle. So,
I have not seen it from doing an aspirate, but I have seen it twice. Just the disseminated, which I'm sure you're like, I've seen it, 10 times that, 100 times that much. But yeah, it's very dramatic when you see these degranulation events and gosh, these poor dogs. And I don't feel like there's a whole lot. I mean, aside from the local reaction and potentially treating there, when it's systemic, and throughout the whole body, I don't feel like there's a whole lot that we can really do in those cases.
Typically, no, if they're pretty sick from it coming in, if it's sort of like I suspect this is going on or I know this is going on in this patient, I think it's always worth, if they're not on steroids, like trying some steroids and seeing if you can reduce that immediate reaction. But it's a very important reminder of how powerful our immune system really is and when these cells are designed to do things that protect us, but go a little bit wild. So I always joke that like I don't really want to boost my immune system. Like I'm very happy with where my immune system is just now because a boosted immune system is something like a mast cell degranulation, and I just don't want that. So I try to use that phraseology like let's keep my immune system's doing exactly what it needs to do. I don't need to boost it.
Man, that's an image right there. I feel like that's such a powerful message to anybody who's dealt with mast cells is, yeah, let's just like let the immune system do its thing. It doesn't need to be any more powerful than it already is.
Right. Yeah, exactly.
Wow.
Exactly.
I wanted to circle back to the prognostic panels real quick and where their utility lies. What about like a grade one where we didn't get complete margins? Is there a utility with the prognostic panel there, or is it just we need to go back and get more tissue slash monitor?
There would be a lot of opinions on this. So this is just my opinion. If you had a grade one tumor that was a low grade and your margins were at least a millimeter in any direction, depending on exactly where you took this off the dog, I would not do a prognostic panel on that patient and I would just watch because the recurrence rate for grade one low grade tumors is pretty minuscule. Even in incompletely excited, like you're flat out did not get it all. It's a grade one low grade. I don't worry so much about those. Now, if it's in a weird spot where like recurrence of that tumor is going to be so problematic that you might have to do something like a digit amputation or some, I've had owners, they get them on their ear and they're very attached to the ears and they don't want to do a penectomy or something like that, then potentially you could try to assess the risk for recurrence or just go back and get more tissue. I don't know that the prognostic panel would help too much for that. I don't know if that is coming across clear, but for me it's really reserved for grade 2 tumors in that nebulous land and mostly for the grade 2 low grades to sort of support that I'm just going to watch this one.
Sure, sure. No, that makes sense to say if we do have a grade one, even if it's incompletely excised, the chances of recurrence are not incredibly high. And certainly, of metastasis and dissemination, we're not going to worry as much about that. It's one of the nicer players. So a prognostic panel is really not going to have a whole lot of utility. But to your point, if I understood correctly about the ear, because so many dogs, they do have such cute ears, and we don't want to do penectomies if we can avoid it. Maybe something like that where, it's going to be a real problem if you were to have to go get tissue or something like that, but otherwise pretty much reserve it for the grade twos, the grade two low grades.
Right, because I think the other thing I'm always aware of is, and kind of as we led the conversation, is the idea that you can do a lot for one tumor, but think of future tumors in this dog. So having an owner spend, several $1,000s to treat one low grade tumor on a dog that may develop multiple ones over its lifespan, that's where I think the frustration comes from owners. So I'm really trying to be cognizant of like, what is the risk of this individual tumor? What is this problem for this dog? And then, kind of conserving some of the resources in case we wind up with one of those ones where I know we're going to have trouble with that one in the future. So I'm always thinking about that as well.
Yeah, that's such a good point because, you've demonstrated so well here of just the unpredictable nature of these tumors. I mean, it creates frustration for us. We're talking about our shoulders slump and we're like, oh, mast cell tumor. Okay. When we see these and we kind of know the score with them as much as you can know the score with a mast cell tumor, but an owner is oftentimes walking into this without any previous experience, hopefully without a lot of previous experience with mast cell tumors. And now we're telling them, like, we have no idea what's going to happen in the long term. And, even the information we do get can change over time. So, do you have any tips for client communication in addition to, like you said, being cognizant of resources and making sure that we're being very directed in our recommendations, but just trying to ease that overwhelm and frustration that owners can encounter with these?
Yes and no. Having had this conversation many, many times, I always lead it. I walk in the room and it's mast cell tumor. Okay, so I'll tell the owner, I'm going to start this conversation off and let you know if ever there's a tumor that will fool me and do whatever it wants and not listen to anything I'm about to tell you, it's this tumor that your dog has. Now I'm going to go through and tell you the facts and what I think is happening because I feel like that just sort of sets the ground. And I'll revisit that at the end of sort of like, but remember, I said this could do whatever it wants. And having seen so many of them in my career, and they're a very common primary tumor. They're a really common like second tumor that dogs like to get. Like we'll be having a dog on treatment for lymphoma. And they'll pop up with a mast cell tumor. And so it's just sort of like, okay, tell me about how long has this been on your dog? Because that matters. Has this been on your dog for 6 months or more? Because that's generally a better prognosis. Or did this pop up and grow really rapidly over the course of a couple of weeks. So we'll kind of go into some of those things, where is it located on your dog? Because there's certain anatomical sites where I get a little bit more concerned if I see one versus another. I'm just being honest about it and hopefully communicating that this is again, this is shared frustration amongst veterinarians, veterinary ecologists, owners, everybody that they're common, they're everywhere. Most of them are fine, but your dog could have one that's not. And so let's figure out what we need to do about it.
Gosh, I appreciate this conversation so much because it adds a little bit to my anxiety around mast cell tumors. It also reduces that anxiety because certainly in GP where, we're not necessarily going through all of the latest data when it comes to mast cell tumors and we're trying to make the best recommendations, but we run into these walls where the tumor wasn't supposed to come back and it did, or it metastasized when we didn't expect it to, or we removed 4 low grades and then got a grade 2, and it doesn't follow the rules. It can really, I don't know, at least for me, it can make me question myself and say, have I been making the right recommendations? Am I doing the right thing? Because I'm just feel like I'm spinning my wheels sometimes. So I really appreciate this conversation and that it's not that we're not making good recommendations and just spinning our wheels. It's just the nature of these tumors. They're unpredictable and they're frustrating. And we just have to take what they give us and do the best we can with it.
Yep, that's exactly as I would word it. And, I think it's exactly as we teach students, we teach our interns, our residents, and then we get questions from primary vets back to us. And it's sadly, things have not changed very much, but the good news is you're approaching it the right way. And as long as you're having these conversations with owners and empowering the owners to make decisions, and you're making those decisions together to know what's best for that particular patient, then you're doing the right thing for sure.
Yes, that's all you can do. And then at that point, you just have to mentally and emotionally put it down and say, I'm doing the absolute best I can.
Yeah, and if that means starting steroids and just seeing if you get a response from steroids, I think that's totally reasonable. Personally, I think that that's fine. Not every owner. We understand that in referral practice, we see a very small subset of people who are pet owners, and that is totally fine. I think trying steroids and seeing what happens, and again, magically, sometimes they go away, and sometimes they go away forever, and I have no good explanation for it.
Because they're mast cell tumors and they do what they want.
Exactly. Yeah. Yeah.
Um, well, Dr. Intile, thank you so much. Like I said, I learned a lot from the conversation. I feel reassured, empowered
Good.
on a GP level. So I really appreciate it. Are there any final thoughts you want to make sure that listeners are taking away?
That if they get a diagnosis, I guess, of a mast cell tumor in their dog, to not panic. Yes, it is cancer. Yes, it is a diagnosis that requires some sort of action, but that having a conversation with their GP, and that most GPs have good knowledge of this disease and also connection to oncologists who would help them through it. And that it's, again, if they ultimately decide to come for a referral and not do anything at the referral hospital, that is still a perfect day to me. Like that is because I'm providing the information to the owners and again giving them that education. If they want to take that information and go back to their primary vet and take the tumor off, like we are fine with that. Everybody is fine with that. That is still a very productive and happy and wonderful use of my day, especially as an educator, because I'm training students. Most of them are going out into GP. So it's so important.
Absolutely. Well, and I think that really helps give us some backup on the GP front too, to say, oh, you're not doing enough, to hear it from you and say, okay, the oncologist told us that this was gonna be unpredictable and we weren't sure what was gonna happen. And so, yeah, I think it's that symbiotic relationship to say, even if they come back to us and we're doing the surgery, when we do get one of those that just doesn't follow the rules, that the owner has an awareness, not only from us, but also, from a specialist like you who's treating these day in and day out.
Right. Yep, for sure. Yeah.
Well, thank you again. This has been such a great conversation. I really enjoyed it.
You're welcome. This has been a lot of fun. Even though the topic is not always my favorite, it's important to get the information out. So
I can second that.
Perfect.
Thank you to everyone who tuned in. So glad that you did. I hope you learned a lot. I know I did. Dr. Intile, thank you so much for the great conversation. I really hope we can do it again sometime. If you enjoyed this episode, please leave us a 5-star review wherever you get your podcast to help other veterinary professionals like you find this and other great content we try to put out there. If you'd like to hear more, you can click on the Education tab on the VetFolio website, or you can find us wherever you get your podcasts. As always, we'd love to hear your input on this talk, as well as ideas for what you'd like to hear in the future. You can feel free to email me at dvm@vetfolio.com. You can also find me on Facebook at Dr. Cassie DVM, or we can connect on Instagram at dr.cassie.dvm. And remember, if one animal is better off because of you today, it's a great day.